Hello, everyone. My name is Kathy Flynn, and I am the National Senior Director of Engagement for the American Liver Foundation. Welcome to today's webinar, Ask the Experts, Living Donor Liver Transplantation. The American Liver Foundation is the nation's largest nonprofit dedicated to serving people with liver disease. Since 1976, we have provided a voice for patients with liver disease and those who care for them through education, support, research, and advocacy. Today's Ask the Experts featured speakers are Dr. Giorgio Roccaro and Dr. Lance Stein, who will be introduced shortly. Thank you, Dr. Roccaro and Dr. Stein, for sharing your time and expertise on today's webinar. And thank you to Jeannie and Jim Goldberg for their generous support of this educational program. At this time, I will turn the presentation over to my colleague, Lindsay Ventura, who will review our webinar practices and introduce our expert speakers. Lindsay? Lindsay, we cannot hear you.
I'm very sorry, I had myself muted to be quiet during Kathy's portion, but all right, thank you very much, Kathy. My name is Lindsay Ventura. I am the National Manager for Outreach and Education. I just wanted to go through a couple quick housekeeping items. First, on the right side of your screen, you should see a dialog box. If you don't see it, there is an orange arrow which you can use to expand that view. So when it's collapsed, it'll just be a small bar. When it's expanded, it'll look more like this. From here, you can ask questions throughout our presentation. We do encourage you to send question and answers along. And then towards the end, once both Dr. Roccaro and Dr. Stein have presented, we will ask your questions to the doctors and get some answers. We've also uploaded some handouts in the handouts section, which you'll see highlighted here as well. It's now my pleasure to introduce our first expert speaker, Dr. Roccaro. Dr. Roccaro joined the Emory Transplant Center in 2018 and serves as Assistant Professor of Medicine at the Emory University School of Medicine and as Medical Director of Living Donor Liver Transplantation. Dr. Roccaro completed his medical degree at the SUNY Downstate College of Medicine and then completed his internship and residency at Massachusetts General Hospital. Subsequently, he completed clinical fellowships in gastroenterology and transplant hepatology at the University of Pennsylvania, while also obtaining a master's in clinical epidemiology. Dr. Roccaro's clinical interests include hepatocellular carcinoma, non-alcoholic fatty liver disease, and living donor liver transplantation. His research interest in improving survival for patients with hepatocellular carcinoma and following liver transplantation. Dr. Roccaro is board certified in internal medicine, gastroenterology, and transplant hepatology. We're really lucky to have Dr. Roccaro's expertise with us today. And at this point, I'm going to pass control over to Dr. Roccaro so that he can present his session.
Okay, thank you so much for that introduction, Lindsay. Just want to make sure you can see my slides.
Yes, we can. Thank you.
Great. Okay. So I will be speaking today about who should consider a living donor liver transplant. This talk has three objectives. The first is to define what exactly is a living donor liver transplant and how is it even feasible. Second, I'd like to answer why would someone choose a living donor transplant over a deceased donor transplant. And finally, who should be considered for a living donor liver transplant? So the first part, what exactly is a living donor liver transplant? A living donor liver transplant is a surgical procedure in which a portion of the liver from the healthy living person is removed and placed into a recipient whose liver is no longer functioning properly. What does this look like? So here's a schematic of a healthy donor. When we're considering adult to adult living donor liver transplant, we're generally considering a right lobe donation. So the right portion, which makes up about 2/3 of the liver mass, is removed surgically from a healthy donor and transplanted to a recipient with end-stage liver disease. Here, the diseased liver is removed and replaced with the healthy graft from the living donor. Now, how is this even feasible? Well, there are several reasons why this can be done successfully. First, a healthy adult has a liver mass that is about 4 times greater than what is minimally required to complete all of its normal functions. What this means is that a healthy donor can donate 60 to 70% of their liver volume. The second reason is that a healthy liver tissue has the capacity to regenerate and grow in both the recipient and the donor. In less than 3 months, the partial liver can reach about 80 to 90% of its original size, and that occurs in both the donor and the recipient. Now, I underline here healthy. What do we define as healthy liver tissue? We generally consider healthy liver tissue to be the liver tissue of someone under the age of 50 to 55 that does not have any pre-existing conditions which can affect liver's capacity to regenerate and grow. That means absence of chronic liver disease, fatty liver disease, or other conditions such as diabetes or high blood pressure, which can impact the regenerative capacity of the liver. Finally, the human liver is naturally divided into these well-defined anatomical segments. This allows surgeons to be able to operate on the liver and divide it into segments to be donated, and to do so with generally minimal bleeding and complications. The anatomy of the liver is divided into 8 segments, and these segments help define what is used for different types of living donor liver transplant. The smallest graft is composed of segments 2 and 3, and that's what we define as the left lateral segment, and that is what's used for transplants, living donor transplants for infants and toddlers who are born with congenital forms of liver disease. A slightly bigger graft is what's called the left lobe, which is composed of segments 2, 3, and 4. That is a portion that's often used for adolescents or small adults. And in adult-to-adult living donor transplant, we're generally considering a right lobe donation, and that is composed of segments 5, 6, 7, and 8. A larger graft is used for adult-to-adult donation because the proportion of liver mass that's necessary to be transplanted is proportional to the weight of the recipient. So a larger recipient necessitates a larger graft. Part 2, why choose a living donor liver transplant over a deceased donor transplant? So there are several reasons for this. Number one, probably the most important reason, is that there is an organ shortage in the United States. Last year, about 9,000 liver transplants were performed, and this was an all-time high. So very encouraging that we're increasing our volume, and this was up 8% from the year prior. However, 13,000 patients were added to the liver transplant wait list. This again was an all-time high. And 11,000 patients unfortunately died or became too sick to undergo liver transplant. What this amounts to is about 1 in 5 patients dying on the liver transplant wait list while they wait for a liver transplant. The second reason is that there is a survival benefit. A study published in 2011 demonstrated for both patients with low MELD, generally considered less than 15, and with those with a MELD of greater than 15 without liver cancer, patients who underwent living donor liver transplant had about a 60% reduced risk of dying compared to patients who were waiting for a deceased donor liver transplant. The reason for this survival benefit is attributed to eliminating the risk of dying on the wait list, where over time, patients can get sicker, they can get weaker as their liver disease progresses, and they get older. Finally, with a living donor liver transplant, you have the potential to receive a healthier liver graft. So when I talk to my patients about the quality of liver grafts, I like to make a comparison to cars. We hope for a top-line model, that Ferrari sports car that can get you from point A to point B in less than 4 seconds. But with deceased donor liver transplant, sometimes the graft quality can be up to chance. You know, if you're really sick, it's really whatever comes next. And you might get a lower quality model that can still get you from point A to point B, but the shelf life might not be the equivalent to that Ferrari. So with a living donor transplant, the graft quality tends to be a known entity. It's not something left to chance. Also with the living donor transplant, there's proximity from the donor to the recipient. Usually those are in operating rooms right next to each other. So that graft has to travel a very, very short distance. So it does not sit on ice very long. and that can impact how quickly the liver graft will work right after the transplant. Fourth, there's a potential for better long-term outcomes, and this is a really important finding. A study from 2014 by Dr. Goldberg and his colleagues demonstrated superior graft and patient survival among living donor liver transplants when compared to deceased donor liver transplant recipients. And that benefit seemed to really start to grow after the 2-year mark after transplant. Finally, the third part, who should be considered for a living donor liver transplant? The general selection for a patient to undergo living donor liver transplant meets the following criteria. One, they should be eligible for and meet all the criteria necessary for a deceased donor liver transplant and be eligible to be put on the wait list. The other criteria are somewhat subjective. The second being that they have not had a prior liver transplant, and this might not be the case at all centers. It's really dependent on surgeon experience, the potential recipient's prior history of abdominal surgeries, and how complex they expect the living donor transplant to be. Third, the recipient should not be overly sick, and that might be defined by having a MELD score of, say, less than 25. Generally, if the patient's MELD score is higher, their chances of receiving a deceased donor transplant and avoiding the risk to a healthy recipient is quite high. Lastly, we generally consider BMI as the body mass index of the recipient can dictate how large the liver graft needs to be. So a patient with extreme obesity or a body mass index of greater than 35 might not be an ideal candidate for a living donor transplant. Thank you.
Thank you so much, Dr. Roccaro. At this time, I'm going to introduce our second speaker. So our next speaker is Dr. Lance Stein. Dr. Stein is a transplant hepatologist at Piedmont Transplant Institute who specializes in liver disease and transplantation. Dr. Stein is a medical director of Piedmont's Living Donor Liver Transplant Program. His special interests include viral hepatitis, both B and C, management of the complications of liver cirrhosis, including portal hypertension, metabolic liver disease, including non-alcoholic fatty liver disease, NAFLD and NASH, and health and wellness after liver transplantation. Following his graduation from Temple University School of Medicine, he completed residency in internal medicine at Emory University School of Medicine, followed by a gastroenterology fellowship at the University of California, San Diego. He also completed a fellowship in advanced transplant hepatology at both Columbia and Cornell New York Presbyterian Hospitals. Currently, he serves on national committees for the American Association for the Study of Liver Disease, the American College of Gastroenterology, and the American Society of Transplantation. Dr. Stein, I'm now going to give control over to you.
Okay, great, thank you. All right, everyone can see the slides here?
Yes, we can. Thank you so much.
Okay, great. All right, so we're going to shift gears into that nice kind of foundation of why living donor is an appropriate option for a lot of our patients on the transplant wait list. And now take a step of, well, all right, you're telling me I should be considering a living donor. How do I go about doing that, right? What are the steps to do the big ask, right? You're asking someone to give you a big gift, if you would. And that's kind of the steps we want to outline and show you the resources that are available. So some of this was already discussed, but why would you want to consider a living donor? Why living donation? Well, the main thing is it eliminates time on the wait list for you. And the ideal is that you're going to get transplanted, your family member will get transplanted, your loved one will get transplanted in a shorter period of time and potentially in a healthier state. It also removes the person who receives a living donor graft from the transplant wait list, and therefore it actually shortens duration for other patients who are waiting for deceased donors, as somebody has now been removed from the wait list and the steps on the scale kind of shift. surgery times for both the donor and the recipient, it kind of happens on when everyone's schedule is accommodated. Really mostly on when the donor is available and the donor is ready and the surgical teams are ready. But really, if you want to do this during Christmas break or the summer, we can start to set those schedules. The donors often step up because they're the type of personality who just wants to help, whether the person is known to them or not. We find that the donors are really, go-getters in life, and they're the ones that really want to have an opportunity to help someone, and there's no bigger gift they can give than an organ. So as a patient, the doctor's saying, hey, I need to consider all my options, getting evaluated for transplant, waiting to be put on the transplant list, or I'm on the transplant list, but I'm sick and I don't feel well, and I have chronic liver failure, and I'm fatigued, and I'm tired. How do I go about considering living donor as an option? How do I find a living donor? So the way to do this is here, right? There are resources available to help you. Here at Piedmont, we have a program called a Champion program. A lot of the large transplant centers will have this, where we can match and identify people to help coach folks on how to find a living donor, or to help educate a potential donor, or the ideal champion is the person who has been identified as someone who's going to help kind of carry the weight for you. So you don't have to do it by yourself, right? Let all the others do the hard work. We understand that our patients come to us with, end-of-life diagnoses and severe illness, and are often incapacitated. And they don't often have the ability to concentrate and do the hard work it takes to do some of this stuff. So rely on your family, rely on your loved ones. It can be a team of people if there's not that one person. Some people come from smaller social networks or smaller family groups. You can have one person. You can have, if you're from a larger network, you can have a lot of people. If you don't have anyone, the transplant programs often can recommend maybe a prior transplant recipient or a prior donor who could become your champion. But you don't know these things often unless you're asked, or the center has a program in place to educate you on this. And then anybody can really be trained to be a champion. The programs often will have the resources available to train folks who are interested in becoming champions for you or for someone you know. And like I said, if you don't have one, one can be provided. It's important that if you're interested in living donation, that you have to go out and find folks who are willing to donate for you, right? Donate to you, or donate to your loved one. There's a lot of strategies out there. We found a lot of success with social media, right? Social networks really help reach large audiences. And sometimes, you've asked your family and you're trying to keep it quiet, and they all say, I can't do it, I have a medical problem, I don't qualify, just not now. That's okay, right? I mean, everybody has limitations. Not everybody can be a donor at all or today. But there are other people out there that you may not know about, right? So your cousin might have a huge social network. So if you create a story on Facebook or a blog, and it gets shared, and it gets shared, and it gets shared, and you kind of grow exponentially the eyeballs of potential people who could help the situation. You might find someone who maybe was someone you went to college with who you haven't spoken to in 10 years, who reads your story and feels compelled to reach out. We've seen all sorts of really interesting stories be created through our patients, creating these networks to find potential donors and to get their story out there. Talk to your family members. Often children and grandchildren are really good if you're not social media savvy, about creating pages, the right things to say, to kind of get the story out there and promote it. Update the story if you start doing that. And if people want to hear how you're doing, and it will start to capture more eyes eventually. Work with the family circles, right? Circles and circles and circles. People know people. Word of mouth. Stop talking about it. It's important that people keep reiterating the need. If you are a candidate for living donor and you are interested in doing it, keep up the persistence of finding a potential donor for yourself. we often find that religious groups and offline social groups are really good avenues for our patients too. We've seen members of church step up and say, I don't know this person personally, but I know they're in my church group. I'm willing to help. We've seen all sorts of connections be made. Bring any donors, right? Bring all donors. The way it works is we ask that the donors reach out to us independently of the patient who's on the transplant wait list, because of course we don't want to have a situation where we find some coercion where you're kind of forcing the potential donor to step forward. We want them to do this on their own, right? This is something that they have to be able to understand what the risks and benefits are and really want to be able to do. So we ask that they contact us, but the more the better, right? So the more donors you have, the more likely we're going to find one that accepts. The acceptance rate runs around 20%. And so there's a lot of reasons why donors might be declined. Sometimes it's simple as a blood type mismatch. Sometimes it's due to their medical history. Sometimes it can be due to prior surgical history. Sometimes it could be due to personal reasons. There's a lot of reasons why someone ultimately might be declined. So the more you have that come forward, the ideal. I think a lot of the centers aren't great about working with multiple donors at one time, but that's probably the ideal way to do it, for multiple people to kind of move in synchrony through the process to get evaluated. And it gives centers the ability to potentially choose the best one or find one who's the best match, whether it's size or otherwise. And work with the center to push them, right? You should be an advocate for yourself, but the family should be an advocate. Always push the medical teams, regardless of the cause, regardless whether it's transplant or not, because we're here to work with you, and sometimes we don't understand what the individual needs are until you tell us. So another thing that comes up is altruistic donors. So altruism is someone who's really doing something for the good of someone else, right? A selfless person. And we find these pop up on occasion. Someone wants to just give, right? We had a donor recently come forward for a kidney donation at our center and was declined for their potential recipient. And the guy was like, you know what? I just want to donate. He couldn't give a kidney, so he goes, you know what? I'll just donate half of my liver. And we were like, wow, you sure? That's great. Let's work together. Let's see what we can do. And he went through the process and ended up becoming an altruistic liver donor. And that type of situation happens, right? We found patients who say, I'm just going to do this. I don't know anybody to give to, but I found it in my heart that I need to give part of my liver and help someone in need, and maybe be helping multiple people, because again, when someone comes off the wait list, other people also are being helped. And they're just going to do it. And as long as they're appropriate donors, we will accept those, and the transplant centers will accept those, and we will find an appropriate donor match. We really like those recipients of altruistic donors to be the recipients who have tried for themselves to also be living donor recipients. So meaning you've reached out and you've had family members or loved ones or distant connections reach out to us and be evaluated. And if there were no matches found, we found that altruistic donors are perfect for those potential recipients. So stay focused, stay positive, right? Living donor is not for everybody. For the donors, not everybody also for the recipients. You will find that some donors will just tell you, no, that's not for me. And don't be hurt by that, right? This is someone's own medical decision. They have to be able to be willing to undergo major surgery. There are risks with that. They will be out of work for a couple of weeks. There will be healing that will take a couple of weeks, sometimes a couple of months. There's a risk of complications. There is extremely rare risk of death, but a real risk of death. So some people will say it's not for me. Some people are being asked to have to care for their own families, and they will prioritize that over the potential risk of doing donor surgery now. So you should be respectful of that, and be respectful when people say, I'll consider it, but maybe don't respond. It's okay to be persistent, but also be willing to accept the no. Also be aware that You know, you might have a tree full of donors, and for whatever reason, centers might decline them all for one medical reason or another. That will happen. Some donors might be perfect. Some donors might go through the evaluation process. Some donors might be accepted and then kind of get cold feet at the last minute. It happens. It's okay. They're allowed to do that, right? It's all about safety for everybody involved. But like I said, stay focused, stay positive, stay persistent. We found that our persistent recipients or candidates for transplant really do the best at finding living donors. So what's the future, right? I will tell you that living donor liver transplantation, despite being around for 20 plus years in the United States, remains in the infant form. It really is a growing resource. The transplant teams are learning a lot about how to do this and how to do this well. The success rates, as Dr. Roccaro has outlined, has really improved over time. The expectation is that this is a better option for most people than deceased donor transplant for all the reasons we previously outlined. But there are a lot of ways that I think the transplant centers who are doing living donor could do better jobs at finding donors and utilizing potential donor organs from living donors. A couple of strategies to do that are coming forth in the future, and we're learning a lot of this from the kidney transplant world. Number one is paired exchanges. So let's say there's a blood type mismatch. Valve A is a blood type B, and then the donor is a blood type A. That's a mismatched blood type. Potentially, you could find another family pair who's in the same situation, but cross donors, right? That's what they do in the kidney world a lot. We just don't have the computer algorithms quite set up in the transplant the liver donor world for doing that just yet, but things are coming. But that is an option that we are looking at. There have been centers, particularly out of Asia, that have reported utilizing donors across blood types. It's an accepted method now. However, not really being done in the U.S. There's some increased rate of complications, but potentially in the future that might be an option. And really the future is going to be in computer or algorithm exchange programs. The complexity with living donor rather than kidney is kidneys often can be harvested and shipped across the country because there's time on its side with the donor organ out of the body. It's not quite the same with liver. So it's just a little bit more complex, but potentially this is a world that we expect to see grow as computer technology also grows along with it. And the living donor rates are increasing the last couple of years, increasing probably because of awareness is increasing, the safety of this is increasing, and more importantly, the allocation for deceased donor has changed, many people are aware of, which has reduced the availability of deceased donor organs, increasing the need for truly re-exploring the living donor pathway. All right, that is it. Thank you.
Thank you so much, Dr. Stein. I really appreciate that. I'm going to now bring up some of our questions that we had asked during this program. So some of the first questions we had asked were related to MELD score. One was, do you have to have a high MELD score to be considered for living donor? And how high does your MELD really need to be to get on a deceased donor list? So I think this is, kind of how to make that decision between deceased donor and living donor based on your MELD.
Sure, I'm happy to answer that. So for living donor liver transplant, there's no, or for liver transplant in and of itself, whether it's living donor or deceased donor, there's no minimal MELD score needed to get onto a liver transplant wait list. Essentially, you need to be deemed to have end-stage liver disease, meaning cirrhosis with complications of liver disease, which drives the need for liver transplant and dictates a survival benefit from having a liver transplant, whether it's living donor or deceased donor. Old studies have demonstrated that risk-benefit ratio in favor of liver transplant tends to occur when the MELD score is greater than 12 to 13, 14 or 15, kind of in that range. However, that can differ across certain types of liver diseases, particularly with cholestatic liver diseases. Patients who have conditions such as primary biliary cholangitis or primary sclerosing cholangitis, who can often be way sicker than their MELD score indicates. Those are two conditions in which living donor liver transplant has really been shown to have a survival benefit over waiting for a deceased donor liver transplant. So in summary, there's no minimal MELD score needed to be listed for a transplant, either living donor or deceased donor. As for a cap on MELD score for living donor, again, there is no cap to it. You can have a living donor liver transplant with a high MELD score. However, the higher MELD score is, the higher likelihood you are to receive a deceased donor transplant. You'll be higher on the list, and therefore it's the ethical principles of not introducing harm to someone who's otherwise healthy as a donor is probably not needed, in which case it makes sense to probably wait for a deceased donor.
And Dr. Stein, what do you think about this question? It kind of goes along with that. So how soon before you're really sick should you start the journey of finding a living donor? When should somebody start the process? Say they're at the point of compensated cirrhosis right now, they have a lower MELD score, maybe not even, up to even 7 or 8. When should they start to consider identifying their own living donor?
Yeah, so that's not a cut and dry answer for every patient. The answer really is individualized. So we will consider anyone for a living donor transplant as long as they are having complications from their liver disease that we believe will improve from a liver transplant, taking into account, again, those risk benefits that Dr. Roccaro mentioned. So the MELD score in itself doesn't truly guide who should be considered. It's generally the complications, right? So we know that MELD score over 15, transplant, hands down, needs to be done. When the MELD score is under 15, but someone has complications that are leading to life-altering changes, a common one would be hepatic encephalopathy or confusion related to liver disease. Another one might be what we call portal hypertension, and having gastrointestinal bleeding related to high pressure in the liver. We will consider those patients with lower MELDs for living donor if there's no other alternative strategies available to them. So not a cut and dry for every patient. I recommend just talking to your doctors, particularly the transplant team. I think where this gets a little dicey, and I think Dr. Roccaro will agree with me, is a lot of times patients are being cared for their liver disease in the community by gastroenterologists who understand the message in general that a MELD score of 15 is when to refer patients to the transplant center. But I think what they don't understand is that if a living donation is in play and someone otherwise is recommended to have transplantation, an early referral is important. So we would like to meet people earlier who are having complications from their liver disease, and we do our best to get that message out to the practicing gastroenterologists so they understand that message, but that's really a new treatment paradigm. So, any patient at any MELD should at least ask the question, should I be considered for living donor?
Great. Dr. Roccaro, do you find that people are less likely to donate a liver to a person who's sick because they may have suffered from the effects of alcohol-induced liver disease or alcoholism?
That's a difficult question. I think that's individualized. And certainly there is still in our society stigma around alcohol liver disease and the question of someone who has a quote unquote self-inflicted liver disease, are they worthy of receiving this gift and should I be putting myself at risk to help someone? But I often counsel my patients and their family members that I consider alcohol liver disease to be like almost any other liver disease that I treat and manage, is something that has relapses and remissions and is often a chronic lifelong battle, and that disease is not just cured at transplant, but it's something that is treated for after transplant through counseling and relapse management and medications. And just having the diagnosis of alcohol liver disease is certainly not a contraindication to living donor, and it's certainly a good reason to consider living donor liver transplant as opposed to waiting on the list for a deceased donor that may not happen, as Dr. Stein alluded to, if someone has cirrhosis and complications of their liver disease. So it's a difficult conversation to have, but I think that still even patients who have had alcohol liver disease are worthy of living donor liver transplant, and those are conversations I like to have with patients and their prospective donor and family members together, so that those stigmas are put to bed. And something that Dr. Stein alluded to is discussed about how early is too early. I don't think it's ever too early to have a conversation with your loved ones and family members about the state of your condition. And even in someone who has compensated disease and may not be in need of transplantation at this moment, 5-10 years down the line, there could be progression of symptoms, and it's better to have these open conversations at a time when there's no rush and less stress.
Right. Yeah, that sounds like there's some good programs built in around counseling around that, so that's helpful. And one last question: what percentage of liver transplants are from living donors? And perhaps you could even talk about how many other countries experience living donation in another way than we do here in the U.S. So I'll let you guys decide who covers that question.
All right, Giorgio, I see you nodding your head. Take it.
I think in the U.S. we're currently less than 5% of all liver transplants are living donor transplants, and that proportion is rising, but has not risen nearly to the capacity that living donor is being done in other countries, particularly in Asia, in South Asia and East Asia, where living donor liver transplant is the predominant form of transplant. And it's done for not only patients with end-stage liver disease and symptoms of liver disease, but also for patients with liver cancer. And a lot of our surgeons here in the U.S. go and spend time in Japan, Korea, and in China learning methods of living donor liver transplant where they're really far advanced. So that paradigm is something that we are working on changing a little bit here in the United States because of so many of the benefits we discussed about living donor liver transplant, but there's a lot of work to be done. The other portion that's of interest is that in some of these other countries where living donor is the predominant form, there are religious there are religious barriers to deceased donor liver transplant, so therefore it's not as common. I don't know if Dr. Stein, you had anything else that you would add to that?
No, I agree. I mean, I think the main issue is that living donor is just one strategy to increase the donor pool, right? And that's the big reason why we're all here. In the ideal world, there would be donors for everybody, deceased donors for everybody, right? Because there's no risk to a potential living donor if everyone had deceased donors. But that's not the world we live in, and the surgical teams have gotten really good about utilizing organs that in the past would have been discarded. So the donor pool and the deceased donor rates, like we said last year, was an all-time high at 8% rise. A lot of it's because the types of donor organs we are learning how to utilize that, how to use the imperfect organs, if you would, and have them be successful. And we also need to start seeing some commitment from governmental organizations to help us increase awareness and donation from deceased donors. So right now, the U.S. has kind of an opt-in policy. You check your box on your driver's license and you can be an organ donor, or family members need to consent for a potential deceased donor. There are other countries who have an opt-out approach, right? And there's much higher rates per capita of donation. And that would be, a perfect world where everyone is opting in, and we may or may not need living donor. But if living donor is part of that equation, the living donor rates would also increase through events like today and awareness and, more centers performing this and performing it well.
Thank you both. And I think, that's a great point that we are able to use a lot of different organs now that maybe we couldn't in the past. And so it's important to never count yourself out as a donor, whether for living or deceased donation. At this point, I'm going to pass it back to Kathy, but thank you both, Dr. Roccaro and Dr. Stein, for asking your questions. If you are viewing this webinar after the live recording, please do feel free to leave your questions in the comments, and we'll be sure to get back to you as soon as we can. Kathy?
Thank you very much, Lindsay. On behalf of the American Liver Foundation, thank you to everyone who's attended today's webinar. Certainly, if you are in the greater Atlanta area, we encourage you to reach out to these fabulous resources at Emory and Piedmont to learn more about living donor liver transplantation. And we certainly invite you to visit the American Liver Foundation website and access resources that are listed on our website and through our social media channels. As a reminder, all attendees will receive an email with a YouTube link to this webinar, as well as the Living Donor Liver Transplant Toolkit that accompanies this educational program. Lastly, a very special thanks to our expert speakers, Dr. Roccaro and Dr. Stein, for sharing their expertise and time with us today. And a word of thanks to Jeannie and Jim Goldberg for their philanthropic support of the American Liver Foundation's Living Donor Liver Transplant initiatives. Thank you, everyone.
Thank you.